Hi, good morning. We are going to be working today on reporting and identifying abnormal symptoms of COVID-19. What that looks like for those of you working in a short-term rehab or long-term care setting. So the goal of today's lesson is to educate CNAs, LPNs, and RNs of the steps that are needed to recognize COVID symptoms in the patients that we care for. Some of the objectives that we'll be working on today is all direct care staff will be able to verbalize when a patient is having abnormal symptoms of shortness of breath, hypoxia, or muscle weakness, what that looks like if you are the clinician that's caring for those patients. Objective number 2, CNAs will be able to identify abnormal vital signs that may identify with COVID-19. So sometimes we don't recognize as clinicians those changes, even at the point where they're very minimal, and it goes from a patient being pretty stable to non-stable and needing to be sent out to the hospital for emergency situations. So we're going to talk about those and what we need to kind of look for. And lastly, the RN or LPNs, those nurses on the short-term rehab unit, will be able to identify when patients may need further diagnostic treatments related to COVID-19 and kind of what those diagnostic treatments look like. So let's get started. Some topics of discussion within this PowerPoint will be the COVID-19, what COVID is, vital signs, what's abnormal versus normal, documentation. What do you document? That's going to be huge. The abnormalities in COVID-19 patients, and then again, the diagnostic tests to rule out or confirm COVID-19. So we're going to just watch this video by Dr. Frida McRae. She's going to talk to us about the symptoms of COVID-19 and how we recognize these symptoms. So at this point, we would watch the video for any of the students in the class. So the first objective, all direct care staff will be able to verbalize when a patient's having abnormal symptoms such as shortness of breath, hypoxia, or muscle weakness. So this is pretty big for CNAs. They don't sometimes recognize those changes that they see. They may notice somebody's huffing and puffing, but they don't really understand specifically what to do. So big lesson for CNAs here. First, hypoxia is low oxygen in the tissues. The symptoms that you want to monitor for both nurses and CNAs is changes in color of the skin. Sometimes they can be very, very red, very flush looking, and sometimes they can be blue where, you look at their lips and they have a tinge of blue, or, they're very blue. A big thing with hypoxia to notice, especially in our elderly patients, is confusion. So you have a conversation with somebody who's alert and oriented times 3 to 4, and you come back in the next day and they're just off a little bit. They're repetitive in what they're saying to you. They just don't seem to be at baseline. So that's a huge, huge, huge change that sometimes we don't recognize. Sometimes we feel like maybe it's just contributed to dementia, but not necessarily. So we do need to be taking a peek at what that pulse ox looks like. Other forms or symptoms of hypoxia include cough. You can have a fast heart rate, rapid breathing, shortness of breath, slow heart rate, sweating, or wheezing. So thank you, WebMD, for those symptoms that we should be monitoring for with hypoxia. Some more in objective 1, shortness of breath. So what that means is you're consciously thinking about breathing even when you're at rest. When we sit and we breathe, we don't really think about it. Sometimes we have to stop and take that really deep breath where we do have to consciously think about it. With shortness of breath, a lot of times people are always thinking about it. They can't take that deep breath. They can't get enough breath into the bottom part of their lungs to get those things moving. So shortness of breath symptoms is that they can't fill their lungs with air. If you have a patient that's complaining about that, you need to be letting the nurses know, or nurses, you need to be grabbing your stethoscope and listening to them, counting those respirations for a full 1 minute, and making sure that if you're seeing something labored, that you're definitely working through the process of what we need to do with that. Some other symptoms are needing to pant. So you walk in, somebody's bent over, breathing really hard, can't catch their breath. That's panting, like very similar to an animal or a dog, where they just went for a run and they're breathing hard, breathing hard, breathing hard, trying to just get that breath into their lungs. Excuse me. Some other symptoms is that they can't hold their breath. Every inhale makes them cough. They feel like they're suffocating, or saying, I just feel like I can't breathe. I feel like I can't get enough air in my lungs. Those are all symptoms of shortness of breath that really need to be monitored. And then chest tightness or pain with breathing. So if they're telling you that they feel like there's an elephant sitting on their chest, or they just have bricks or rocks on their chest, we need to be monitoring and checking and assessing for what else could be possibly going on, as these are all some of the symptoms that people have with the COVID-19 virus. The last part to objective 1 is muscle weakness. So sometimes in muscle weakness, we have our patients who they go up and they go down. Sometimes they can transfer themselves, sometimes they can't. So it does get a little bit difficult to recognize when these patients are actually having a change in condition and when this is just kind of part of their current routine of working through rehab. Some of those symptoms that may indicate muscle weakness that we may not recognize, and we want to listen to our patients when they're telling us, is that burning feeling. If they're saying my muscles feel like they're on fire, I feel like I just can't stand anymore, I can't transfer the same, I need somebody to help transfer me. All of those things that may be out of baseline for those patients, those could be a sign of muscle weakness. Muscle weakness is a primary symptom of COVID-19 that sometimes I think is kind of missed. It's people take that again as oh, they're going through rehab, so they may have more tired days and less tired days, when it can come on gradually, or it can come on very suddenly. So we do have to be paying attention to those things. Muscle weakness, some other symptoms, they're starting to have falls. They're not able to take steps like they were prior, or transfer like they were prior. They're saying that their muscles are shaking, so they're having spasms, complaining of pain, just flat out not being able to move a limb. It's numb, it's got pins and needles, they're not lifting it as well or moving it as well, and then kind of twitching in the muscles. So all of those things contribute to muscle weakness, so we need to be paying attention to those things. Moving along, so objective number 2, our CNAs will be able to identify abnormal vital signs that may identify with COVID-19, and will provide nurses with a report of the patients who have these abnormal vital signs. So what does that look like? So when we're talking about vital signs, obviously everybody kind of differs. You have your patients whose temperatures are between 97.8, 99 degrees. That's pretty typical in an adult patient to have a variation in their temperature. What we need to be monitoring for is a temperature of 100.4 or greater with having COVID symptoms. So this is going to indicate to us that there is some kind of change. Typically when we see low-grade fevers, those can come across for a number of reasons. They're working really hard, their body temperature is up, the warmth in the room, things like that. So A heart rate for an adult patient has a pretty big variation between 60 and 99 beats per minute. So what we see with COVID-19 patients is a heart rate of typically 100, 105 or greater. And those start to indicate that that heart is working double time, triple time, overtime to try to just get that blood circulating through the body, as it's just working so hard to breathe and to, keep all of those vital organs moving. So again, when we're looking at respiratory rates, 12 to 16 breaths per minute, up to actually even 20 respirations per minute is pretty normal for an adult patient. So when you're really seeing them huffing and puffing 24, 26 respirations per minute, we really need to be counting those for a full minute and making sure that we are paying full attention to what that looks like. They're trying to get that air in, and that can indicate, obviously if they just took a walk, just got back from transferring, doing something like that, they're going to be, the respiratory rate's going to be a little bit elevated. But give yourself some time. If you don't believe that what you're counting or what you're saying is appropriate, grab your nurse, grab a manager on the floor, one of the supervisors, and just say, hey, I need a double check. I need somebody to just, take a quick peek at this patient. Blood pressure can vary with COVID-19. So, we like to say we like blood pressures between 120 and 80, but how realistic is that in this environment? Pretty minimal. Most patients who end up in rehab typically are on some type of blood pressure medication. So what we need to be looking for is, has our blood pressure increased or even decreased 30 points from systolic to diastolic? Have those numbers changed? Typically the blood pressure is increased with COVID patients, and what occurs with these is that heart is trying twice as hard, triple times as hard to beat, to get that blood moving, to get, kind of get the blood to where it needs to be to help fight this virus off. So paying attention to that. And then pulse ox. So according to the nursing SOS, 95 to 100% is pulse ox. Obviously, we know with our COPDers and our asthma patients, things like that, their pulse ox aren't typically up at 95%. So what we want to be looking for is probably 92 or less if a patient has a normal pulse ox of 95 to 100%. If you have somebody who's breathing on a normal basis of 90%, when you start seeing them get into that 88, 87, 86s, that's where we really need to start paying attention and focusing on kind of what is happening with our patient. What is the change? What is going on? So for you CNAs that are in this course, one of the big things for you guys is make sure that you're documenting all of this. Even if you have a temperature of 100.4, you're letting your nurses know. That is key. Those nurses are responsible for these patients to make sure that they're getting the appropriate care and that they're getting to the doctors to get the diagnostics for what we need to do next before these patients do become an emergent situation. So we're going to just take a little peek at this next video, when to be concerned. This video is just going to tell us a few things about, what some COVID things look like. What are those symptoms? What can be occurring on a day-to-day where you don't even recognize that you may have some symptoms of COVID. So take a peek at that. All right, so on to objective 3. The RN or LPN on the short-term unit will be able to identify when the patient needs further diagnostic treatments related to COVID-19. They'll do that within the shift, and they'll be able to provide a detailed report to the providers. Excuse me. So there's a few different diagnostic tests for COVID-19. The molecular test is a viral test. You put a swab into the nose. Sometimes your facility may have rapids where you can put it in and have the results within 15 minutes. Please understand that these rapid tests are only 50% accurate. They likely do need to be sent out for PCR. In some situations that I have had in my own personal experience, we have had a lot of those things that come. They are positive, and then we get them back, and then they actually they're negative, or vice versa. So again, we want to be paying attention to those things, and making sure that we're advocating for those, for a PCR to be sent out regardless, because PCR is just more accurate than those rapid swabs. Another test is the antigen test. That's nasal or nasopharyngeal. So again, those are quick 15 minutes tests. Positive results are usually highly accurate, but false positives can happen. So again, this is kind of the same situation. Is we need to be doing both the rapid so that we know, we should be isolating everybody for 14 days or 10 to 14 days, depending on the CDC guidelines, so that they are not exposing other people. We also should be doing our gowning and gloving and full PPE per the facility protocol when we suspect anybody with COVID-19 symptoms are happening. But then we would do the antigen test. If that comes back negative, but we still feel like they're having symptoms, we should still be sure that we're sending out for PCR, the molecular test that we were speaking of earlier. And again, those quick antigen rapid tests, sometimes they actually miss an active COVID-19 infection. And so we just want to be sure that as the nurse and the nursing staff that we are processing through all of these things and letting our docs know when we feel like there needs to be a little bit more diagnostics happening. So lastly, there's an antibodies test that occurs. It's typically a blood draw. Some people can give it to you the same day. It does not show if you have a current infection. It shows if you have had a past infection. So it shows whether you at some point previously have had a diagnosis of COVID-19 that you may or may not have known about. And then lastly, a CT of the lungs. So if you're suspecting as a nurse that there is COVID-19 occurring, a patient's getting worse, you're starting to see some respiratory concerns, diminishing of lung sounds, things like that, calling that doc, asking, do we want them sent out? Do we need a CT? Do we need to look at maybe possibly having an x-ray done or an ultrasound done of those lung fields in order to verify that there's not something more going on? A lot of times with COVID, patients develop pneumonia and then it progresses pretty quickly into respiratory failure, which then actually is the typical cause of death with COVID-19. So when we look at the CT of the lungs, it's different. The lungs of a COVID-19 patient actually look different than those of somebody with pneumonia, bacterial pneumonia. And so there are very, very specific things, cloudy lesions that appear like glass. And I'm sure everybody's heard that those are those ground glass opacities that we need to be looking at. And when the docs are seeing those, it's pretty clear that these are the lungs of somebody with COVID-19 versus somebody who just maybe picked up a bacterial or a viral pneumonia. So that would be a pretty great diagnostic test to show what COVID-19 actually looks like. So when it comes to documentation, we always document. So if it wasn't documented, it wasn't done. For my nurses, monitor your vital signs that are being put in by your CNAs. If you're seeing something, 99.9 and you're a little concerned that it's starting to raise, ask those CNAs or those techs to retake those vital signs. There's nothing wrong with double checking or even walking down and checking and doing an assessment on your own. This is going to save a lot stress from, if somebody is having minor changes to having emergent changes where they have to be sent out. And then CNAs, make sure that you're documenting every and all vital signs. If somebody has a temperature of 100.4, put that in the system, even if your nurses are asking you to retake it, because what that's telling us is, hey, there was a change, even for a brief moment. That could have changed. It could be environmental. It could be the fact that maybe your patient, they just had a hot cup of tea and they're having some flushing in their face, something like that. So, but we want to know, if we're seeing those changes, if they're coming and going and coming and going, it could mean that something may be happening and changing within their body where we need to be given a call to the docs. So that's kind of the COVID-19 in a nutshell. Here are some references for the information that was shared today. And, if you don't know, ask. There is never a dumb question. There's never anything wrong with asking questions. So I'm going to open it up for questions right now.